Do you have an advance directive? Should you? Do your loved ones? How do you talk to them about it? How do you talk to your patients about it? Find out today. Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Welcome back to the podcast. On today's episode, we have a super special episode. I know I say that like every time, but this time we really do, because we have a physician who started off as a listener and she had messaged me on Instagram. And so we'd had some exchanges. She, gave me some ideas for topics, and it was really, a super helpful exchange. And now she is a guest to help you be a better physician. And so we have Dr. Eleanor Tanno, who is a practicing full-time family physician in Rockville, Maryland, and the founder of Advanced Directive MD. She went to med school at the University of Maryland and family med residency at Virginia Commonwealth University. And she's the founder of Advanced Directive MD, which is what we're going to be talking about today. She's passionate in educating her clients about creating a meaningful, specific advanced directive to eventually guide their families in honoring their end-of-life wishes. So, Dr. Tanno, thank you so much for being on the show.
Thank you. It's truly an honor.
Well, thank you. Thank you. Let's dive right into it, as we always do. Let's just clarify some terminology because, as we say on the show, everything we should have been learning while we were memorizing Krebs cycle. And it's not to say that this stuff isn't covered in med school and residency. It's just, I definitely need a review myself. So let's start with just what is an advanced directive?
So an advanced directive, it's, the definition is if it's a set of instructions that you create to guide somebody in how you would like your end-of-life care to go. So basically, you leave them directions. And it has two parts. So part one is naming your medical power of attorney. That's your medical decision maker. And part two is defining these medical wishes.
So we're going to take a deeper dive into what is contained in an advanced directive in a little bit, but there's still some other terms that I'm not so sure about. So you said naming your medical decision maker. So that's your power of attorney. I thought that was your healthcare proxy.
So they're all the same thing. There might be some legal differences depending on what state you're in, but typically all of these are interchangeable. So it's like your healthcare advocate, your medical power of attorney, your medical decision maker, your medical surrogate, healthcare surrogate. It depends where you are, what terms they use, but they basically all indicate your decision maker if you're not able to make your own decisions.
And does power of attorney have any overlap with other legal issues? Like your power of attorney covers your healthcare proxy, but also they are like your executrix, which is like the person that executes your will.
Yeah. So there's a completely separate legal power of attorney. So my strength as primary care is to know what I don't know. And so your legal power of attorney is different from the executor of your state. These are different terms. They could all be the same person. And then your medical power of attorney is the person who makes your medical decisions for you, or the person you've named to make your medical decisions for you.
So I guess that makes more sense to me now, because power of attorney can cover both legal and healthcare. But when you're talking about healthcare, your healthcare power of attorney and your healthcare proxy are basically the same thing.
They're the same thing. That's it.
Okay.
It's just the one person that's named as your decision maker.
And then what about pulsed and MOLST? Because, when you're taking care of an inpatient, it'll often ask you as you're admitting them, do they have a MOLST?
Yes. So there are there's an umbrella under end-of-life care documents. So one is your advanced directive. And this is something that everybody should have at every stage of life. Whether you're 25 years old or 100 years old, you should have an advanced directive. And again, that has the two parts, the medical power of attorney, that's your person who makes your decisions for you. And part two is defining your medical wishes. Also under the umbrella of end-of-life documents would be something called a POLST form or a MOLST form or a MOST or a POST. It depends what state you're in. They're essentially all the same thing, even though each form might be state specific. And these are medical orders for essentially first responders to follow, in the initial stages of your care. And who should have a MOLST, or and in Maryland, we call it a MOLST where I am, but POLST, POST, they're all the same thing, essentially. Who should have one? These are people who are at high risk of ending up in the hospital, specifically in the next 2 years, close to end of life, or have a significant illness where they have a high likelihood of ending up in the hospital. And this has, specifics like, do you want dialysis? Do you want a ventilator? If you have a DNR order, it would be designated on that post form.
But then how is that different from an advanced directive?
So an advanced directive, remember, so the advanced directive is where you would name your medical power of attorney, part one,
Okay.
and then your general medical wishes. So it's different in that the post form is really intended for somebody who's likely to end up in the hospital, and you would complete that form with your physician or your nurse practitioner, depending what state you're in. Whereas an advanced directive, you might complete with just witnesses. You don't even necessarily need an attorney in most states. So they're just sort of different. So one is more overview, like general document, and the other one is much more specific, as you are more likely to end up in the hospital.
Wait, you said the advanced directive, you need to have an attorney present when you're writing
You
that?
do not. No. So it depends on most states. You don't need an attorney. It just needs to be witnessed. And only a few states does it even need to be notarized. So you can, if you Google like your state, New York, and then you do advanced directive, you'll get probably New York State has their own advanced directive that you could just print out and you could go home, look right now, and you could complete it and you could have a witness sign it, basically.
Okay. Makes it legally binding. So like you could have someone like forge it.
I think in most of them, you might need more than one witness. So it'll be like two witnesses, and then
Like
the witness
requirements for the witnesses. Like they can't be a relative or something like that.
well, they can't be the person you've named as your medical decision maker. But yeah, that's one of the biggest things is that people always think that they have to make their advanced directive with an attorney, but really you can make one with probably nobody, or you can make one with a physician. So that's actually how I got into this. So when I was in the hospital in the ICU, I saw all these people who had advanced directives who were made with state attorneys, like 20 years ago. And they all said the same boilerplate. If I have a terminal medical condition, no heroic measures.
Lawyers do.
Yeah.
Right?
And so when you're in the actual setting and you have this patient who's critically ill, there's a moment of like, I don't actually know what this document means in this scenario because it's just too vague and too legal. It's not at all humanized in a way that's useful. And so I thought, rather than people making these with attorneys, they really should be making these with physicians. And so that's how I even got into this whole thing was I was like, what would I educate people on? How would I reinvent the wheel here a little bit?
And the fact that when I was doing research for this episode, and when I say doing research for an episode, that usually means I listened to the audio version of the book or I listened to some previous podcast interviews done by other people. When I was looking for material on advanced directives, some of it was in the healthcare space. A lot of it was from attorneys. Like that's still who's writing this stuff. And it makes so much sense because they don't know what it's like. Like they don't know what end of life care is like, unless it's their like very niche field of theirs.
When I talk to estate attorneys about this, they're like, oh, we hate doing that part of the estate planning because we don't really know anything about, not that they don't know anything about that, they can't answer any specific questions. They're actually pretty uncomfortable with a lot of this in many scenarios. And actually, when I teach courses on this to people, a lot of times somebody in the audience might be an estate attorney. I just had a guy the other day, he was retired, and he said, in my 30 years of doing estate planning, basically he said that after my lecture, that he learned more in, that 30 minutes than he knew during all of his career. So, we just had a practical, different approach to these things.
You spend some time in the ICU, you know what end of life looks like. You take care of these people. You're able to think through these problems. You get it. There's been all these articles about how doctors die differently.
Exactly.
And there's a reason for that. And it's not a very good one. Like, it's amazing that you're doing this because really you can move the needle on healthcare spending. Something like a fifth of healthcare spending is in the last 6 months of life. Some like preposterous number. And so if we're able to, let's put you in the shoes of a policymaker. So let's say universal advanced directives, like that's going to be some healthcare initiative in order to decrease spending and, help people to improve the quality of their death. And this was part of Obamacare, right? Which was like, well, we're going to create a billing code for billing for discussion of end of life care, right? So you come in and you've got like bloody noses, fine. We'll fix your bloody nose. By the way, you're 98 years old and you have a bloody nose because you're on Coumadin. Do you have an advanced directive? No. Okay, let's talk about this too. Now I can bill for the bloody nose and for the discussion of advanced directives. Now, this was politicized and they were like, Oh, you're going to be cutting people off after 70 years old. The death, I forgot what they called them, the death
The
something.
death panels.
The death panels. Yes, the death panels. So super politicized. All we want to do is be able to bill for it. But let's say, right, let's put you in this position. You can wave a magic wand and we have a policy that's going to make, how would you execute that? What would you want to do?
So it's interesting. So this is what I always tell families is when you haven't had these conversations, people, they will generally opt to do more care, aggressive care, prolonged care, because nobody wants to feel like they withdrew care from their mom. And so they err on the side of doing more. This is what everyone does, right? When you're not sure what to do, you take the path that doesn't limit you later. So that's how that even happens. But in terms of, how I would actually move this needle, one, I would reimburse more for these discussions. So, if you add the code for advanced directive, advanced care planning to a regular office visit, it's like $100. It's somewhere between 100 and 125. It's not enough for the amount of time that this conversation takes, which to have a quality conversation about this could probably be 45 minutes, kind of minimum, especially if you're filling out any documents together. So one is I would reimburse like way higher for that. And two, I actually,
you're still going to save the system a ton of money.
that's true.
Right?
You're right.
Reimbursing, it's like investing in education. I mean, and that's really what you're doing. You're investing in education. You're spending now to save later.
I would potentially bill more. And then the other thing is I actually feel like I would make it almost like I think it should be a requirement of getting on Medicare. I don't know, requirement sounds a little strong, but it's like when you sign up for Medicare, I think you should have to almost like a driver's ed, right? Like a quality course, arguably taught by a physician on end of life care. And I think just take that black box away because it doesn't need to be dark and scary. I mean, when I talk to people about these decisions, it's a conversation about like values, like what is important? How do you picture end of life? What do you consider quality? What deaths have you seen that are scary? What have you seen that are, don't look so bad kind of thing. And so I think having with people, when they go on Medicare, I think it'd be a good idea to have some education that goes on there. Now, of course, practically, I don't know that this would ever happen. And I have not a whole lot of faith that this would be a quality experience for most people. I think it'd be like a check the box thing. In an ideal world, people would take a quality course on just what happens with end of life care. When I teach courses on this, there's so much confusion about do not resuscitate orders. So I always show a video of what CPR looks like.
Oh.
And then we talk about, it's a good video. Don't worry. I choose one where it's a happy ending. The guy survives and does very well.
It's not what really happens in reality.
Well,
right?
no, but I do. Yes. So I give the statistics of, fewer than 10% of people leave the hospital alive. But anyway, teaching what CPR is so that you can then come back and talk about do not resuscitate orders, just because there's so much confusion. I mean, when I ask patients, do you have an advanced directive? A lot of times their answer is, oh, I'm DNR. And this is like a healthy 60-year-old patient. I'm like, I'm pretty sure you're not DNR because I haven't signed a do not resuscitate order as a physician for you. So there's just so much confusion. I think just even a basic course or basic understanding would be so helpful to get people to have these conversations.
Well, there's also something else that you do that makes it fun. I saw this post on Instagram. Your death deck. What is it?
Oh.
Death deck.
So when I teach people about advanced directives, and I teach courses, right? So I talk to my patients about this, but I also teach individual courses. And there's different resources. So sometimes I recommend like the Conversation Project is one that has great online resources. 5 Wishes, it's a document that can be a legal advanced directive. So there's certain things that come up that people ask about, but I also recommend. And then, yes, I just did a unboxing of my death deck. So it was actually pretty fun. You can buy it on Amazon. It's like a deck of cards, it's like $15 or something. It's almost like Cards Against Humanity but a version of death deck. And so each question was, I was looking through them and it was something like, you're about to buy a house and you find out somebody was brutally murdered inside. Would you still buy the house? And it was like A, B, and C of like, of course I'd still buy the house.
Outline still there.
And so the idea is that you would, I guess I'd have this conversation with the people around you. So like you and your spouse one night could have a glass of wine and just sort of like go through these questions, but it would stimulate conversation and bring up ideas that otherwise you wouldn't maybe naturally ever talk about. And there were more like, how would I like to be cremated? Would I like to be cremated? Things that are more like on the death spectrum. And then there were others that were a little more lighthearted, like the serial, like the murder in the house kind of thing.
It sounds like table topics, which is something we have for our kids.
Oh,
You might, when yours are a little older, it might work where it's like, if you could have one superpower, what would it be? But you're like,
yes.
if you were to be cremated and your ashes were going to be spread, where would you want it to be?
No, yeah, that's actually one of them. It was like, would you
Oh,
want your
really?
remains to go into space? And I'm like, haven't even thought, like, who thinks about this? But I think the idea is just to have sort of a topic and then get into some details together when you talk about it.
Let's say you are a primary care physician and you want to be doing more of this. Like, what have you found to be an effective way when the patient's coming in for something completely different? What's your opener there?
Yeah. So, I mean, technically, part of the annual Medicare wellness appointment is to ask, do you have an advance directive? And a lot of people say yes, when they meet with a state attorney, or they say no. And if they say no, or they indicate that they're interested, depending on the amount of time I have, what I do is I usually give them a copy of the Maryland Advance Directive. And I just very briefly walk them through it because I know that if somebody handed me, a 15-page document, I would just take it home and put it in my trunk and never open it again. And
Yeah.
so the idea is like, I show them, I show them it's not that scary. The first few pages are just frequently asked questions. The last few pages are like, how do I sign this thing? And then there's only a few pages of the actual advance directive. And so I just kind of walk them through it. And then I say, take this home, read it, come back, and we can have a whole appointment just for this. That's what I do if I don't have a lot of time. It's just a quick, like, here it is, go home and read it. If I have more time, I'll actually start to go through some of it with them and answer questions. But that's how I do it in that setting. And then there's other times where I bring it up. So not too long ago, I had a patient who she had a somewhat new diagnosis of interstitial lung disease, ILD. And with that one, it was diagnosed maybe a year ago. And she's had a rapid decline in the last couple of months. Like, she's been in the hospital. It's essentially every 2 weeks, she's in the hospital for 2 weeks. This is the exact patient who should be having these discussions and it's scary for everyone. It's scary for me as a doctor. It's scary for them because also, as primary care, I'm not her pulmonologist. I'm not her ILD doctor, but I can say, you know what? I'm worried that the next time you go into the hospital, there might be a time where you're too sick to make your own medical decisions. Have you had these kinds of conversations with the people who would be involved in your life?
There
Well,
might
thank
be a
you.
time when you'll be too sick to make your own medical decisions.
Yes.
Like,
And I say, I am worried.
yeah.
And I think that's, I've learned that from palliative care doctors and then, we have a conversation about that. But I have that conversation. Anybody who I see has been in the hospital, 3, 4, 5 times in the last 6 months, maybe they have heart failure and they keep going back in. That's when I have that conversation. No, I don't have it with a healthy 60-year-old marathoner, but I do have it when I'm constantly seeing them for, hospital follow-up visits. It's like at some point I have to have this conversation. I'd hope that their cardiologist, oncologist, pulmonologist, whoever is like managing the underlying illness has had these conversations, but it never hurts to have more than one person have this conversation. And a lot of times they haven't had this conversation or they haven't heard it.
Does it happen that like the cardiologist would expect the primary care physician to do it and the primary care physician would be expecting the cardiologist to do it? And then so nobody ends up doing it?
I think it really depends on personalities. I think some people have these conversations and some people don't. And
Yeah.
I think some specialties in general, like you can't group by specialty. I think it's really hard. I think oncologists often have these conversations. It just depends. So I would never assume that they've had this conversation.
Yeah.
I would just hope.
I think that's a good way to approach it. Assume that they haven't.
Yes.
Assume that they
Or
haven't.
sometimes I might ask, have you had a conversation with your cardiologist?
It might even
Just to feel it out, just so I'm not like, scaring them after they just had this conversation yesterday with somebody.
Yeah. I think qualifying it with recent. Also, have you had a recent conversation? Because they might be like, yeah, I talked to my estate planner about this 20 years ago. I have an advance directive. And you're like, wow,
Yeah.
that might not. And speaking of which, like, how often should something like this be updated? Right?
Yeah.
'Cause I'm imagining it's not like a regular cadence, like every 2 years.
Yeah.
But like, what would prompt you to be like, listen, that sounds like it might not be as relevant now. Maybe we should go over it.
Yeah. So this one, this actually has a name. It's the 5 Ds. So one is the 5 times that you should definitely update or at least consider updating it. So one is distance. If you have moved states, you should check and make sure that your advance directive is, still up to date in that state if you need
Still
a new
binding.
one.
Yeah.
Yeah. Although they're usually honored across state lines, but just in case. So divorce or marriage. So anytime you have somebody who may or may not, well, essentially what it is if you don't have a power of attorney, the default is a spouse followed equally by adult children, unless you've named somebody specific. And so if you have a divorce, who was the person who had been your default may no longer be, or if you get married, that person might be your default and maybe you don't want them to be. Maybe you're 30 years old and you just get married and you've known this person for 2 years and your mother still expects to make your decisions for you if something happens, right? Like these scenarios happen.
I saw an Instagram post about that where like all of the men still had their mother as the emergency contact, and the women had switched their emergency contact to their spouse.
Yeah. Number 3, so we said distance, death, every decade. So if you make an advance directive, say in your like a lot of people will make their first advance directive in their 40s when they do an estate plan when they have little kids. Like that's a common first time for people to even think about this. And then I would say every 10 years or so, you should think about it. If
Like you said in the 40s when you have little kids, because that's when doctors have little kids.
Well,
other people have little kids in their 30s. We have
well, I'm thinking more like you have them in your 30s and you're getting around to it as your 40s. So so every decade of life, I think you should consider updating. Just look at it, see if it still stands. So like what you want at 40 is different from 50, is different from 90, right? Like at 90, I think a lot of people would say, don't do any, aggressive medical interventions. And at 40, most people would say, every medical intervention.
Yeah.
And then anytime you have a big update in your diagnosis, disability, any kind of decline, anytime there's a kind of a pivotal change in your health, that's when you should also update it.
And
I hope I said 5.
Death. Then then it's too late.
Death, number 5, death of a spouse. So because if that person was your default medical power of attorney, then you want to, or the death of your power of attorney, you should update it then.
Yeah. And I guess that's a major enough life event for you to reconsider, those priorities too. Gives you a little more perspective. Yet another reason to update it. Okay. So I think we did things in a little bit of reverse order because the question that it's really important to get to, we're getting to kind of towards the end of the episode, which is like the types of things that should be included in an advance directive. So you said like there are forms, states have forms that we can go through. Let's say you were writing an advance directive de novo. What would be the main issues that would need to be addressed?
Yes. So, when you look at advance directives, they're kind of, like I said, boilerplate. They don't add a lot of detail. So when I talk to people about advance directives, I tell them to come up with what I call their litmus test for medical decisions. So a litmus test is any test you apply to a situation that gives you a kind of definitive yes or no answer. And so the litmus test for medical decisions is, and this is not something that you can think about just, offhand. You have to go home and think about it. But I would want to be kept alive as long as I am still healthy enough to. So I would want to be kept alive as long as I am still healthy enough to blank. So you need to think about, and this changes throughout your life. Like, right now as, young people, it's like, I want to be, pretty independent. I would never want to, like most people, you would want a lot of independence. As people get older, that changes. And I had a patient, this was just a classic, it's just a perfect example of a litmus test. So she was 92 years old and we were talking about her advance directive because I was worried that she might end up in the hospital soon, given her health conditions. And we were talking about the advance directive. So I said, what's important to you? What's your minimum quality of life? What's key here? And she said, I want to be able to take care of my 96-year-old husband. And I thought that was like the best litmus test, because if this patient showed up in the emergency room or the ICU and was really, really ill, as doctors, we can read all the advance directives that say something like, keep me alive, don't keep me alive, persistent vegetative state, whatever sort of legal jargon's in there. But what we can say is, at the end of this ordeal, will she be able to take care of her 96-year-old husband? And if the answer is most definitely yes, then we would pursue the aggressive medical care. Yeah. If the answer is almost certainly no, she's going to go from here to an acute rehab, live in a nursing home the rest of her life, whatever it is, then I would not, continue aggressive care. Or say her husband had already passed away and she was just kind of ready to go. So in that case, that's an example of a litmus test. Like, I want to be able to take care of my 96-year-old husband. And so that's when I tell people that advanced directives, I tell them not to sweat the details of like, would you want a ventilator? Would you want dialysis? Would you want antibiotics? The question is, what do you want to come out of this whole ordeal looking like? What kind of state of medical independence or health do you want? And I think people, when they hear that, it's suddenly like a light bulb goes off. Like,
Yeah, that's an amazing
I
question.
want to, like I want to be able to get myself dressed. I never want somebody else to have to bathe me. Like, these are basic things that when you start to think about them, they're so much more important than I want a feeding tube for 2 weeks, but stop it after that because I wouldn't want a peg tube. It's like, what's the end goal here? Like, what's the
Yeah.
big picture? And that's
Yes,
where
you're right. There are too many
Yeah.
variables. There are too many
Yes.
variables to be able to keep track of. Like, give me a statement of your values, and we
Yes.
can extrapolate from there based on the specifics of your situation. Yeah.
Exactly.
Amazing.
Exactly. So that's where the physicians are better at this than the attorneys, because I think we can say, when you're in these really bad health situations in the hospital, like, what's the end goal here? Like, what are you trying to do at the end of this? And if the answer is, I want to live in a nursing home and not be able to talk to anyone, okay, then like that's a very low bar. We can probably make that happen.
Yeah.
But if it's like, I want to be able to walk my dog, well, that standard's kind of high.
And then the family gets it too, right? Then the
Yeah.
family is going to be able to be at peace with, well, we did everything she would have wanted us or he would have wanted us to do.
Yeah.
Right? That gives them a lot more closure. Well, yeah, the doctor said there was no way. This is what she would have had to look forward to if we pursued this. And
Right.
clearly she wouldn't have wanted that. So yeah, I think and we're saying she more often than he because the women outlive the men. And so the women have already made this decision.
I also see like 90% women in my practice. They all find me. So I'm just much more common. It's more common for me to have a female patient. But yes, men need to have these conversations too. They can't just leave it to their wives, their moms.
Yes, but they should be accompanied by a significant other when they're having these conversations. That's one of my rules. When I have a man that comes in, I'm like, did you come here, by yourself? They're like, no, my wife's in the waiting room. I was like, can we get her, please? Because you're going to minimize everything that you're here for, and you're not going to remember anything that you tell me. Yes, that I tell you. So
visit isn't over until the wife hears the plan.
Exactly. Because she's going to want the one that's going to be responsible for executing on it. Well, okay. So if people want to find you online, if they want to find Advanced Directive MD, where do they find you?
There's a couple places. So one is they can find me at advanceddirectivesmd.com. And there I have a step-by-step guide for advanced directives. I also have a newly launched online course. So it's really not intimidating. I've taught this many times, but I decided to record it. It's 6 20-minute videos, essentially. That is a great tool if you've been meaning to have this conversation or you feel like your parent should have this conversation. That's a great, I'm just really excited for that because it's been really fun to record it. And then they can find me on Advanced Directive MD on Instagram. And then the same thing, Advanced Directive MD on Facebook. But I'm probably most active on Instagram, but really my website is where all the resources are.
Fantastic. Well, thank you so much for all you're doing for our patients and your patients. And thank you so much for your time. And thank you for listening.
Thank you. It's an honor again. Thank you.
Thanks for listening. So please share it or like it or comment on a social media post or write us a 5-star review. Thank us again for listening to The Physician's Guide to Doctoring.